Now we're going to do a brief examination of the neck. Physical examination begins with inspection. We look to see whether or not we see any work of breathing. We would see work of breathing by tenseness of the sternocleidoid mastoid muscle, which was drawn out for you. You would also see intercostal retractions as well. You can also have, remember, supraclavicular retractions or infraclavicular retractions, and that means a sucking in on inspiration and indeed a bellowing out could be seen on expiration. I notice whether or not the trachea is midline. Recall that there are certain disorders that will cause the trachea to deviate towards the problem or away from the problem area. On inspection, I also notice the jugular veins. If a patient has fluid volume excess or other pathologies of the heart, we may see jugular venous distension. Typically, we'd like to use the internal jugular vein, but you can see on this drawing that the internal jugular vein is hidden by the sternocleidoid mastoid muscle. So many times in clinical, we will use the external jugular vein as a measure of fluid volume excess. So again, I'm inspecting to see if I see the jugular veins. I'm inspecting the trach. I'm also inspecting whether or not I see any asymmetry in the thyroid. If a patient has a goiter, that is an enlarged area of the thyroid, we will notice asymmetry. After I inspect the area, then I move to palpation. So for palpation, I would like to first begin with nodes, and I would check the submental node. I would check the submandibular nodes, and again, I'm feeling to see if I feel anything like a little pea underneath the skin. I feel the anterior chain, and I'm rubbing to see if I feel any softness, the posterior cervical chain. I also check pre-auricular in front of the ear, posterior auricular, and I check occipital. If I had a lymph node that was enlarged, it would feel like a small pea underneath the skin, and that would be termed lymphadenopathy. Additionally, we're going to check supraclavicular, and we're going to check infraclavicular to see, again, if I feel any pea. Also on palpation, we want to palpate the thyroid. Posteriorly, stand behind the patient, put your hands on either side of the patient's thyroid or on the trachea, and ask the patient to swallow. So will you swallow? And I think you might have been able to see the thyroid rise up, and you can actually feel it against your fingertips. And again, we'd want it one more time. Have the patient swallow, and you feel the thyroid rise up. And what we're feeling for, is there any nodules or, again, asymmetry of the neck? Again, under palpation, we'd like to check the pulses. I compare the pulses, the carotid pulse from one side, again, against the other side. Depending upon what hospital setting you work in, we have different grading systems that are from 0 to 3 or 0 to 4. So it's important that you know what grading you use on the institution that you work at. 1 is obviously absent, 2 is weak, 3 could be normal, and 4 could be full and bounding, or again, we would drop that down. Once I finish palpating the pulses and comparing one side to the other, I would like to see whether or not we have a bruit. A bruit means turbulent blood flow. And so what you're going to do is you're going to take the stethoscope. You can feel the carotid to make sure you know where the carotid is. Typically, if we have a bruit, the bruit will be noticed at bifurcations where there's turbulent flow. So what you're going to do is you're going to place the stethoscope. You're using the bell of your stethoscope to listen, and you're going to have the patient take a deep breath and hold it. And as he holds it, you are listening to hear if you hear whoosh, whoosh, whoosh. So you will hear a noise when the patient's pulse is happening. So we're going to listen on one side, and we're also going to listen on the other. The reason they have to hold their breath is this is a very quiet sound generally, and the patient's inspiration and expiration could absolutely hide it.